So just to start off, my name is Rishabh Chawla. I use he, him pronouns, and I'm one of the co-presidents here of Students for National Health Program.
I'll go next. My name is Layla Bond. I use he, they pronouns. I'm the other co-president. That's about it.
I am Joseph, also go by Quinn. I am the secretary of SNAP and I use he, him pronouns.
Hi, I'm Neve O'Neill. I'm the advocacy chair right now, and I use she, her pronouns. Nice to meet everyone.
And Layla, I believe you had a few words to introduce Dr.
Okay, yes, good. I wasn't sure if you were ready. Yeah, so I have an introduction that I'm going to read for Dr. Gise. So Dr. Leslie Hartley Gise is a 79-year-old retired psychiatrist on Maui, where she's been for 26 years. Before that, she was in New York City, where she did private practice for 30 years. She loved every minute of it and was sad to quit after she and her husband moved to Maui because of the intrusions of managed care. On Maui, she worked for 20 years in the public sector, treating disadvantaged people with severe mental illness in a community mental health center and at the hospital. Half of the patients had substance use disorders as well as psychiatric disorders. Dr. Gise is a clinical professor in the Department of Psychiatry at the John A. Burns School of Medicine at the University of Hawaii in Honolulu. She started advocating for Medicare for All 17 years ago and has made many single-payer presentations for both professional and community audiences. Through PNHP, she's been mentoring a family practice doctor in California who organized the family practice doctors in her local county. Dr. Gise mentored medical students in Honolulu, and they formed a SNAP chapter. She sees today's medical students as our future and was very impressed to see how effective medical students can be on June 8th, 2019, when they got AMA to pull out of the Partnership for America's Health Future, which was organized at that time to kill the ACA. She is working to get the Maui County Council to pass a resolution supporting Medicare for All. Dr. Gise is involved with both disaster psychiatry and women's mental health. The latter includes substance use disorders in women and the criminalization of pregnancy in women who use substances. Her hobbies are tennis, reading, travel, advocacy, and visiting her grandchildren in Brooklyn.
Thank you, all of you, very impressive. So I bring you greetings from the island of Maui, from our beloved Haleakala crater on a unique Ahina Hina silver sword plant. I have no disclosures. I thank you for inviting me. I'm deeply honored by your asking me to speak to you today. So when we look around at healthcare injustice, we may feel hopeless and despondent, but we cannot yield to these feelings. In 1963, in a Rolling Stone interview, the singer and activist Joan Baez said, "Action is the antidote to despair." She's 80 now, and she's still advocating. Each of us has the power to act, and the time to begin, especially for you as medical students, is now. Learning more is a good place to start. Remaining apolitical is a political stance. In addition, during the COVID-19 pandemic, senior medical students have graduated early to join the physician workforce. This year, a colleague in the American Psychiatric Association Disaster Committee co-authored an article in Military Medicine about medical student involvement in disasters, which talks about preparedness, knowledge, working as a volunteer without getting paid as well. The article is in my list of references for this talk, which I could send you, and it's Winokur 2021, which is here. So, as requested, I'm going to talk about three things: our healthcare system and your careers, our healthcare system and mental health, and the mental health crisis, and our healthcare system and the COVID-19 pandemic. One, our healthcare system and your careers as graduating medical students. Few, or almost none of you, are likely to go into private practice. Most of you are likely to take jobs in very large organizations as employed physicians and practice more remote care. In the 1930s, when my orthopedic surgeon father went to medical school at NYU, medical students were greeted with the dean telling them, "Look to your left, look to your right. One of you is not going to be here in 4 years." At that time, a third of students flunked out. Despite the challenges, students continue to flock to medicine. It's a wonderful profession, and no matter what the economy does, there are always sick people who need to be taken care of. It's a rewarding and fulfilling career. But there are new obstacles and problems. For some of you, psychiatry may be an especially fulfilling specialty because every patient is different, as opposed to general medicine treating hypertension and diabetes, which are more or less the same. But of course, as a psychiatrist, I am totally biased. I graduated from medical school at Columbia in 1967. 4 years ago, I was honored by being asked to speak at the 50th reunion. At a class luncheon, I went up to the table with the dean and with the benefactor for whom the school is now named. I asked them what tuition was 50 years before. They had no idea. One classmate who'd been on scholarship thought that tuition had been $1,500 a semester, or maybe $2,000 a year. Sadly, most of you will graduate today with significant debt, which will force most of you to disproportionately consider money, instead of being able to put your interests and lifestyle first. I was blessed with being able to work in private practice half-time and academia half-time for most of my career, over 20 years in New York City. At the Academic Medical Center, I did consultation liaison psychiatry, doing psychiatric consultations on medical and surgical patients, inpatient and outpatient, and women's mental health, with a lot in OBGYN. Private practice was time-consuming and sometimes puzzling, but not stressful. I loved every minute of it. Academia was stressful, with pressure to publish and academic politics, but it was stimulating and definitely worth it. I was sad to quit private practice after 30 years after we moved, my husband and I, and the reason I quit is because I was unwilling to put up with the intrusions of managed care, which we did not have in New York before that. On Maui, I wound up working in the public sector in a community mental health center for 20 years, where I got a salary and could take care of patients without having to do billing. Today in Canada, which has a single payer system, there are more psychiatrists in solo private practice than there are in the United States, and many are paid to work part-time in academia or primary care. Not only do they get paid more than American psychiatrists, but they spend considerably less time doing non-clinical documentation and filling out forms. And the system is set up to help psychiatrists and other doctors relocate to underserved communities. Today in the United States, private practice is disappearing rapidly, and most of you will become employees of large organizations. You will likely be practicing more remote care, telehealth, telepsychiatry, which mushroomed during the pandemic and are not going away. Hopefully, some of you will go into administration and leadership and do what you can at an institutional level to improve clinical care. Hopefully, some of you will make a commitment or continue your commitment to advocacy. Medical students can make a difference, as exemplified by SNAP, which is your chapter. An example is the two medical students, Alan Krita Sadula and Rex Ty, who in the summer of 2019 organized in Chicago a very large rally outside and a die-in inside AMA headquarters. The rally was large because they managed to collaborate with many other social justice organizations. And here you see Here lies a friend who could not afford her medicine, etc. These actions resulted in AMA pulling out of the Partnership for America's Health Future, which is a group of dozens of rich, powerful groups organized recently with the sole purpose of killing Medicare for all. These actions demonstrate how impressive and effective medical student activism can be. The AMA could not ignore medical students because you are our future. 2, our healthcare system, mental health, and the mental health crisis. Our healthcare system not only discriminates against mental health, but has also changed the practice of psychiatry. The focus used to be on both psychotherapy and medication, but now primarily or even entirely focused on medication. Psychiatrists don't do group or family therapy anymore because there are no billing codes for those services. In addition, clinicians are burning out or experiencing moral injury. Access to mental health care is limited by our healthcare system, which leaves 45% of us, that's 40 million of us, either uninsured or underinsured. Because mental health care is not profitable, commercial insurance discriminates against mental health services. Private hospitals tried to reduce their exposure to low-income patients and reduce or eliminate unprofitable services like emergency psychiatric care. Stigma is another barrier to mental health services. Historically, mental health services were set up separate from medical services. 20% or 1 in 5 adults have a diagnosable psychiatric disorder, which includes substance use disorders. And there is no health without mental health. According to the World Health Organization, mental illness is the leading cause of global disability, and substance use disorders are the second leading cause of disability. There are more financial barriers to mental health care as compared to other health care. Coverage for mental health and substance problems is less generous than coverage for other conditions. So there are disproportionately more uninsured and underinsured people who need mental health treatment. Medicaid is the de facto funder of mental health services, especially for those with severe mental illness. Medicaid is an underfunded, half federal, half state welfare program. In addition, insurers limit the number of outpatient visits, offer lower reimbursement rates, impose cost sharing, set benefit limits, and for substance use treatment, often provide no coverage at all. Compared to whites, Blacks who need mental health treatment find cost twice as often the reason for not seeking care compared to reasons of stigma or minimizing symptoms. Over a lifetime, 50% of the population will suffer from at least one psychiatric disorder. Western society maintains a stoic work ethic that holds that people should be in control of their feelings and that mental illness represents a loss of control. People with mild disorders are labeled the worried well and are seen as weak-willed and self-indulgent. Many, including health insurance companies, are concerned that these patients will overuse medical services and deplete healthcare funds by the endless use of psychotherapy known as the Woody Allen syndrome, because the film director, writer, actor, comedian, musician spent most of his life in psychotherapy. Insurers limit inpatient and outpatient mental health services more than other medical treatment. We do have parity laws which state that mental illness should be covered the same as physical illness, but private insurance companies have become expert at finding loopholes to avoid paying for care which they view as unprofitable. But studies have found that people who use even a very, very small amount of mental health care, even one visit, use less medical care. Outpatient psychotherapy offsets the cost of medical care by 20%. Studies show that psychotherapy does not lead to overuse of services. Patients with severe mental illness do better with combined medication and psychotherapy. For patients who don't want to take medication or who are pregnant, psychotherapy is cost-effective for depression, which is more prevalent in women and around pregnancy, where it is a major public health problem which affects the whole family. 1 out of every 3 medical patients has symptoms of anxiety or depression, and these patients do not do as well and stay in the hospital longer than patients who don't have mood symptoms. Psychotherapy has been held to a higher standard than other medical treatments, despite the fact that it is found to be effective and cost-effective. Most psychiatric services are delivered in primary care settings, not in specialty mental health settings. Most of the psychiatric problems you will see in clinical practice are the garden variety, mild to moderate anxiety or depression, but there is a severe shortage of psychiatrists, so psychiatric referrals are a problem. The collaborative care model is a way to address mental health needs in primary care. Collaborative care uses a population-based model. Psychiatrists work with other mental health professionals in primary care settings. The collaborative care model is a long-time tested and proven evidence-based model for delivering psychiatric services in primary care. It is strongly supported by the American Psychiatric Association, which routinely provides a 4-hour training for psychiatrists. But primary care clinicians need to be educated about collaborative care too. And many psychiatrists are not comfortable or experienced in providing curbside consultations. While mental illness and addiction services cause the greatest amount of disease burden and disability, they account for only 7% of health spending. In the United States, we spend about twice as much as other developed countries on health care, but we have worse outcomes. But mental illness, including addiction, is one area of health spending which is lower than necessary. Our market-based healthcare system discriminates against mental health care. Insurers and hospitals favor specialties and services which are profitable, such as cardiac surgery and orthopedic surgery, etc. Insurers pay mental health providers about 25% less than they pay primary care providers for similar services, which leads to psychiatrists not taking commercial insurance. Currently, half of psychiatrists don't take commercial insurance, in contrast to 80% of non-psychiatric physicians who do take commercial insurance. With regard to Medicaid, only 35% of psychiatrists in private practice accept Medicaid, compared to twice as many, 73% of non-psychiatrists who do take Medicaid. Our market-based healthcare system has changed the field of psychiatry and how it is practiced, with managed care starting in the 1990s, that's 40 years ago. Last year, 2 economists, Case and Deaton, wrote a book, Deaths of Despair. I strongly recommend that you read it. They conclude that free market competition does not work well in healthcare. The fastest rising deaths are from the deaths of despair, which are suicides, overdoses, and alcoholism. The social determinants of mental health, abbreviated SODOMH, are a key factor, especially education. Contributing to deaths of despair, is loss of jobs. Case and Deaton point out that with the COVID-19 pandemic, many people lost their jobs, and the jobs are not just a source of health insurance and money. Jobs are the basis for the rituals, customs, and routines of life. Without work, there is loss of meaning, of dignity, of pride, and self-respect, which brings on despair, not just or even primarily the loss of money. Other rich countries have not seen the long-term stagnation of wages nor the epidemic of deaths of despair we are seeing in the United States. The healthcare system is a uniquely American calamity which is undermining American lives. We need to bring social science and medicine together. And here we see that white non-Hispanics in the past 2 decades have had increasing mortality, and it's increasing recently compared to Germany, France, Canada, Australia, UK, and Sweden. In 2017, over 150,000 Americans died from deaths of despair, and these deaths have risen rapidly in the last 2 decades, especially among the less educated. Psychiatry does not have objective outcome measures like blood pressure or blood sugar, so outcomes of mental health treatment are hard to measure, harder than other specialties. So scores on patient satisfaction surveys have become overvalued as measures of quality of both general health and mental health. But good psychiatric care sometimes requires patients to get angry and be dissatisfied, like when doctors refuse to prescribe addicting medications to patients who have a history of misusing them. Opioids are a tremendous problem, and we have an opioid crisis, but opioids do well on patient satisfaction surveys, so doctors are reluctant to deny them to patients. At the Maui Community Mental Health Center, where I worked for 20 years, I ran a lot of weekly groups. All the patients had severe mental illness and had either no insurance or bad insurance, which meant Medicaid. I ran the groups with a nurse or social worker so that we were able to provide one-stop shopping for psychotherapy, medication, medical triage, social and nursing issues. Patients dropped out and came back, but they all knew the day and time of the group and just came back without having to call for appointments, which reduced staff scheduling time. Data indicated that patients who came to group had fewer psychiatric hospitalizations, and when they did get into the hospital, they had a shorter length of stay. But despite many years of lobbying, there is still no payment code for psychiatrist-led groups. So psychiatrists rarely run groups. It turned out that if I billed for a 15-minute medication check, the clinic would get paid more than if I billed for a 1-hour combined medication and psychotherapy visit. Existing public policies do not prioritize psychiatrists treating people with severe mental illness or those who are under a certain income bracket. In public mental health settings where disadvantaged people are treated, low reimbursement rates, low salaries, and understaffing make it difficult to practice outside 15-minute medication checks. These are examples of how the system is rigged to ensure its profit and against providing cost-effective care. Ken Minkoff, a psychiatrist who pioneered the providing of mental health care together with addiction services, coined the term creative sociopathy to describe how psychiatrists and other doctors have to lie and cheat to take care of their patients. White lies like short-cutting, abusive, and intrusive prior authorization requirements, which can require hours on the telephone to get continued approval for a medication which a patient has been taking for a long time and which is working. Managed care intrudes on psychiatric practice and impedes access and affordability. 10 years ago, psychiatric residents in Boston complained that they could not get follow-up care for patients who'd been seen in the emergency department for suicidal ideation. They did one of the first secret shopper studies. Researchers posed to suicidal patients who'd been seen in the emergency department and had been told to see a psychiatrist within the next 2 weeks. The researchers called 64 mental health facilities near Boston, but only 6% were able to give an appointment. Inadequate access to mental health care strains our whole healthcare system. Emergency departments are overwhelmed with boarding psychiatric patients. Insurers are the problem because they have highly restricted provider networks and poor reimbursement. Even if you have what is supposed to be excellent private health insurance, access to outpatient psychiatric care is extremely limited. Even when there is supposed to be parity, equal coverage for mental and physical illnesses, people still can't get care. Access to psychiatric care is not solved by parity with other medical care. It's a symptom of our broken healthcare system, and we need to fix it. 2 years after the Boston study, one of those psychiatric residents, Amy Funkenstein, did a study with colleagues which was published in the Annals of Emergency Medicine. They found that severely ill psychiatric patients who needed immediate hospitalization had lengthy waits in emergency departments due to time-consuming prior authorizations required by insurance companies. They calculated that 1 million hours of psychiatrist time was wasted every year on phone approvals for hospitalization. Insurers hope that these barriers will reduce hospitalizations and save them money, placing profits ahead of patients' health. In contrast, Medicare does not require prior authorization. Managed care has changed the practice of psychiatry and replaced psychotherapy with the prescribing of medication. This is because insurers think that it's cheaper to have non-MDs provide psychotherapy and have psychiatrists only prescribe medication. By the way, I was able to do psychotherapy along with medication for all the patients I saw in the mental health center because they didn't enforce those rules, but many places they do. In the Kaiser system today and throughout the country, institutions hire psychiatrists to prescribe medication and have psychotherapy done by non-MDs, which is called split care. Many psychiatrists believe that having one clinician provide both medication and psychotherapy produces a higher quality of care and may not even be more expensive. Today, patients seek coaches instead of psychotherapy and herbs instead of psychotropics or integrative care. Despite the fact that fewer psychiatrists practice psychotherapy today, there is evidence that psychotherapy is worth it. In 2011, that's 10 years ago, Susan Lazar edited a comprehensive review of the cost effectiveness of psychotherapy, which was published by the Community on Psychotherapy of GAP, the Group for the Advancement of Psychiatry. One chapter from an old mentor of mine cites 22 studies, and another chapter cites 10 studies, plus one unpublished doctoral dissertation. But not all the problems in mental health care in our country are due to our healthcare system. Stigma about mental health is a problem all over the world. Universal health care is necessary, but not sufficient to provide effective mental health care. We should try to get rid of the word stigma and replace it with ignorance. Stigma sounds so fixed and unchangeable. Ignorance can be combated with education and knowledge, a much more optimistic, proactive view. The intrusions and burdensome documentation requirements of our current healthcare system are creating demoralization and burnout among healthcare professionals, including doctors. Burnout must be distinguished from moral injury. Moral injury is when you know the right thing to do, but you can't do it because of the system. In burnout, the problem is in the individual, and remedies relate to increasing resilience in the individual, like wellness and well-being practices such as meditation, exercise, yoga, rest, social support, etc. In contrast, moral injury signals a problem in the system, which could be at an institutional, at a national level, or at a global level. Another problem in access to psychiatric care relates to undocumented immigrants. The ACA Affordable Care Act, otherwise known as Obamacare, banned undocumented immigrants from getting health care in the United States. Undocumented Latinx immigrants are at high risk for depression, anxiety, and other mental health disorders due to stress and trauma during and after migration. Social stresses which contributed to their mental illness includes the threat of deportation, financial burden, limited access to resources and opportunities which provide educational and occupational advancement, vulnerability to exploitation, and lack of social support. Patients on Medicaid have trouble getting mental health care partly because of shortage of mental health professionals in areas which have less than one mental health professional per 30,000 people, which are called HPSAs, Health Professional Shortage Areas. The NHSC, National Health Service Corps, pays upfront for training with guaranteed loan repayment and has recruited a higher percentage of Black and Latinx physicians who are more likely to work in underserved communities. But many trainees do not know about NHSC and or have trouble navigating the complicated application process. Other developed countries like Canada do more to help psychiatrists and other doctors work in underserved areas. 3, our healthcare system and the COVID-19 pandemic. The coronavirus pandemic has highlighted longstanding unaddressed inequalities and disparities in mental health access and outcomes. An example of the higher rates of COVID-19 illness and mortality, an example is the higher rates among people of color. And here you can see in terms of hospitalizations, Black and Hispanic patients have higher rates of hospitalization, and with regards to death rates as well, Blacks and Hispanics have higher rates than whites and Asians. Social justice includes racism, classism, homophobia, transphobia, xenophobia, and others. The social determinants of mental health include education, health, housing, climate, guns, violence, the carceral system, and others. The social determinants of mental health create structural inequalities such that marginalized communities are overly burdened by public health crises, including disasters. And here we see that equality is not enough. The little guy doesn't have a chance to see the ball game. Equity means equal opportunity. This year, 2 psychiatrists, Shim and Vincent, wrote another book, which I strongly recommend that you all read, Social Injustice and Mental Health. They write about how racism and other forms of injustice have contaminated the mental health profession and increased mental health disparities and inequities and reduced access and availability of care. only 2% of psychiatrists are Black, which is down from 7% in the 1990s. And we know that patients do better with doctors who are similar to themselves. Premature death rates are one of the best indicators of population health. And 70% of the determinants of premature death are attributable to environmental factors, behavioral patterns, social circumstances, and access to health care. Life expectancy was already dropping before the pandemic and is dropping more now. We see more from Blacks, and this is CDC data, and even more from in the past year and a half. Early in the pandemic, it was falsely believed that Black individuals were biologically immune to COVID-19, but it turned out that the low number of reported cases was due to lack of testing. In our response to the COVID-19 pandemic, to foster trust so that we could work collaboratively, we have to consider the role that the mental health profession played in institutionalizing disparities. To prioritize health equity, we have to standardize, collect, and make available existing race and ethnicity data in a timely manner. There was also a mental health crisis in the United States before the pandemic, but the pandemic has made it worse. Suicide rates and drug overdoses were high and increasing even before the pandemic. In 2020, more than 40% of Americans reported psychological symptoms and/or substance problems, with rates 3 to 4 times higher than the year before. And 10% considered suicide in the last 20 days. So we see from the CDC, 40% were struggling with problems, anxiety and depression, stress and trauma, substances, and considering suicide. Suicide is now the second leading cause of death for young people. Since the pandemic, anxiety levels have gone up 3 times. Twice as many people have suicidal thoughts. Drug overdoses have gone up 20%. In addition to all that, healthcare workers and other essential workers are at risk for stress-related distress and/or moral injury. So systems must support healthcare workers by acknowledging severe challenges with clear and frequent communications from leaders, by providing opportunities for sufficient rest, peer support, and evidence-based mental health resources for those who develop mental health disorders. Each COVID-19 death leaves 9 family members bereaved, which means that there are more than 2 million bereaved individuals in the United States. Disaster distress helplines have been set up by many organizations, but disaster response work requires outreach. People do not come for help. We have to reach out to them. Mental health services were set up in New York City after September 11th, 2001, but few people made use of them. Today, the physician support line set up for COVID-19 pandemic has more psychiatrist volunteers than people calling in for support, but it is increasing. In disasters, the size of the psychological footprint greatly exceeds the size of the medical footprint. Far more people need psychological help than need physical help, and psychological needs last longer than physical needs. Mental health problems have increased since COVID-19 and are expected to last longer than the pandemic. Long haul COVID-19 has been designated by NIH as PASC, post-acute sequelae of SARS-CoV-2 infection. So we see that depression, anxiety are high among those symptoms. Of patients who've recovered from COVID-19, 1 in 3 develop psychiatric and/or neurological conditions within 6 months of infection, with anxiety and depression topping the list. These patients report persistent anxiety, panic attacks, and being, quote, bedridden with depression. A new medical term has been coined for COVID-19 based phobia, coronaphobia, intolerance of uncertainty, perceived vulnerability to disease, and anxiety or worry proneness. No other viruses since 1918 have had the components of contagion and virulence, the horror that COVID-19 has. Social media may provide support, but may also increase exposure and result in higher levels of depression, also misinformation, social media. Social isolation and loneliness can be overwhelming. Patients who've been in therapy or who had more resilience have been found to be better able to cope with COVID-19's uncertainty, chaos, and stress. Having had a previous mental health or addiction problem predicts lower resilience. Because of mental health stigmatization, psychological symptoms can be ignored or discounted, which makes patients feel trivialized. Relaxation exercises and mind-body interventions may be helpful, as may be app-based tracking of symptoms. With regard to mental health during the coronavirus pandemic, addiction is the #1 cause of preventable illness and death in America. Less than 20% of people who need addiction treatment get it. The pandemic has been stressful, and stress is a risk factor for substance use and relapse, and has been associated with an 18% increase in overdoses. Xavier Becerra, the former Attorney General of California, who's now head of HHS, the U.S. Department of Health and Human Services, reported that in some counties, there were more deaths from overdoses than from COVID-19. And here we see CDC data that the overdose deaths are spiking, almost 100,000 people, an increase in the past 18 months. The pandemic has impaired access to care. People with substance problems who can't contact their regular dealers seek new dealers and new substances, like fentanyl, which increases risk. Job loss and economic problems also contribute to stress, substance use, and relapse. Synthetic opioid deaths increased more than 1,000% even in the 6 years before the pandemic. And that's also CDC data. Online or telephone treatment has helped, but especially with new patients, it's hard to establish a relationship and trust. And many people do not have internet access, this people with substance use disorders, or even money to put on their phones. And 20% do not even have a cell phone. Internet access is another social determinant of mental health. With remote treatment, online addiction groups, including AA, lose the benefit of the informal hanging out before and after the meetings. But on the positive side, some patients have been helped by the loosening of restrictions on remote treatment, including approval of telephone visits and prescription of medications without the prescriber having to see the patient, and permission to give larger quantities of medication like methadone or buprenorphine at one time. For people who have difficulty traveling or who have many hours of travel to get to treatment, remote connection facilitates access to treatment. Remote treatment also improves access for people who are ashamed or fear being seen in a treatment facility. Remote care is more accessible for women who have childcare and other household responsibilities. Because of the benefits of remote care, it will likely continue after the pandemic, probably combined with in-person care. Last month, a former IV heroin user in New York City wrote about harm reduction, for example, needle exchange programs, and naloxone, and using with another person who could administer naloxone if needed to reduce an overdose. She wrote that treating people with dignity itself empowers change, and that those who feel respected are more likely to respect themselves. Humane treatment can spur self-care rather than self-destruction. Participants in needle exchange programs are 5 times more likely to start treatment than people who don't use needle exchange programs. Another significant behavioral problem of the coronavirus pandemic is vaccine hesitancy and/or vaccine apathy. Vaccine hesitancy requires engagement, which is best done by trusted people in the community whom we could coach on motivational interviewing, being empathetic, asking questions, listening, and having patience, etc. Mistrust and misinformation fuel paranoia and anxiety, which are correlated with vaccine hesitancy and avoidance. We can role model by telling patients that we got the vaccine and that getting the vaccine can protect loved ones. This is a challenge for messaging and risk communication. This problem is exemplified by the LDS Church, the Church of Latter-day Saints or Mormons, which endorses coronavirus vaccine, yet women in Utah are still refusing vaccine over fears of not being able to get pregnant. Vaccine apathy is common among young people who feel healthy. They see that most cases are not severe, and they do not think that vaccines apply to them. There are many different types of vaccine hesitancy. Some find getting a vaccine inconvenient, or have to work, or have no time off from work, or have misinformation about eligibility and safety. For people who say they want to wait, we can empathize and say we understand that, of course, anything so new and unprecedented is of concern. Our FedEx driver said he had to work, but when I told him about the first afternoon and evening clinic, he thanked me and took down the information. Our UPS driver thought he had a bad reaction to immunization as a baby, but when I told him that I had worked as medical backup in a vaccination clinic and that we were vaccinating people like him, that they had no problems, he also thanked me. Other people are more fixed in their opposition, citing nature or God, and of course, vaccination has become politicized. It's useless to try to give those people information. The goal is to figure out a way to engage them about their concerns. Social media has played a huge role in scaring people about vaccines. The technique of motivational interviewing engages people around their personal goals and how they can achieve them. It's been used with addiction patients to help them seek treatment. Motivational interviewing is one way to try and engage. For example, if you ask from 1 to 10, how likely is it that you will ever be vaccinated? And suppose they say 5. You can say, sounding very curious, oh, really? That's very interesting. How come it's not 3? So this is an example of a way to try to engage. In conclusion, our healthcare system and your careers. After your training, most of you are likely to be employed physicians, employed by large organizations as opposed to being in private practice. And you are also likely to be doing more patient care. Our fragmented market-based healthcare system discriminates against mental health and has changed the practice of psychiatry to focus almost exclusively on medication as opposed to psychotherapy. 3, the COVID-19 pandemic has highlighted longstanding, unaddressed inequities and disparities in mental health access and outcomes. If you want a copy of this talk and or the slides, you can email me at leslieg@maui.net or text or call me at 808-283-9095. But please remember that we're 6 hours earlier for you. Don't call me in your morning. For advocacy, you have SNAP and Healthcare Now, which you can refer people in the community to our sister advocacy organization and PNHP. And I leave you with this beautiful picture of the West Maui Mountains, which I see out of my window every morning. Thank you.
Thank you so much, Dr. Gise, for that very informative and thorough talk. I think now we're going to go ahead and open it up for questions. We have about 5 minutes left in the hour, but I'm sure we can probably stay extra if it runs over. I believe each of you are able to access the chat or Q&A, so you can leave your question below and Quinn will read it off. Thank you all so much for coming again, for spending your Monday evening with us, and thanks so much, Dr. Gise, for spending your afternoon with us.
All right, I think we got our first question. So, Dr. Gise, would you explain why psychiatrists won't take commercial or Medicaid insurance? Do they typically see private pay patients, or how does this work?
Commercial insurance, one of the barriers is that there's a lot of problems with health insurance being connected to employment, but the 20 years that I was in practice in New York City, many people didn't want their jobs to know that they were in psychotherapy and they had enough money. They'd rather pay cash. They didn't want to use commercial insurance. Commercial insurance increasingly is requiring more documentation and erecting more barriers. The reason that they make psychiatrists do all that documentation is to reduce the amount of care they have to pay for. So it's a burden. Medicaid pays way less and doesn't pay in a timely fashion. So that's why doctors in private practice don't take Medicaid. So the public clinics have people with no insurance and bad insurance because nobody else will take them.
Great, thank you for the answer to that. If anybody else has questions, you can either text them in the chat like Rishabh said, or unmute yourself and go ahead and ask.
So I don't think people are able to unmute since it is a webinar. I see Robin's in the Q&A. So Robin asks, I've read that mental health problems have been increasing in younger generations due to social media. I was wondering, what are some ways to alleviate these problems, especially for younger people who may have unsupportive parents for therapy/medications? That's a good question.
The sad, terrifying news. I've been obsessed with vaccinations and with the COVID-19 pandemic and vaccinations. And I got 2 amazing videos recently with great graphics, and they were short and really communicated against vaccines. So I think that we need to hire those PR companies or PR companies like that to put out short messages with cartoons and great graphics that will reach this audience. And in terms, I'm not a child and adolescent psychiatrist. I did see a lot of adolescents earlier in my career, but when we did an outreach and education project from our state psychiatric society, one of my junior colleagues got a grant and she was over her head. So I spent the whole year helping her, working a lot. I saw that Mental Health America, which is kind of like NAMI, one of the major mental health advocacy organizations nationally, they had a course, Youth Suicide and Bullying Prevention. So most trauma-informed care in schools is directed at teachers to detect signs of emotional problems in kids. But this is a course that is taught to kids, mostly middle school kids. So, kids talk to kids. So this also is a 2-day train the trainer course, which I took, which had all kinds of icebreakers and things where you had to get up and move around and games and great videos and graphics, a great slideshow with videos and everything. And so this is taught to kids so that if they suspect a friend is at risk for depression or suicide or bullying, it teaches them how to respond without blowing it off or being a tattletale. So I was very impressed with that. So this is actually taught in schools in one class period, ideally on 2 successive days. So it's right there in school. So I think that's one way to address mental health problems, educating the kids themselves, not just the teachers. It's important for doctors and teachers and other community leaders to detect signs and symptoms or risk factors for mental illness. But I think teaching peers seems to me to be a powerful way to get the message out. And actually to enlist the kids to do something about it, that they're then empowered to engage and talk with their friend about getting help.
I was going to ask a question. Thank you for that answer. That was really interesting. I was going to ask, what do you think are the best ways for us to combat moral injury in our institutions while we're still vulnerable as medical students or as residents?
So is that how to combat moral injury? Yeah, well, I've been very affected by that. In fact, in the past year, the Disaster Committee of the American Psychiatric Association put out 15 guidance documents, and I volunteered to participate in a small group writing the one about health equity and also the one about moral injury. So moral injury occurs at an individual level, an institutional level, national level, or global level. I've been focused really more on the national level in terms of access to healthcare, but there's a lot that people could do at an institutional level. One member of the committee, Peter Yellowlees, Yellowlees, guy from Australia. He's at UC Davis. He's the chief wellness officer at UC Davis, and he's written a book. He's also an expert in telepsychiatry, but he's put out these messages to all the healthcare workers in the institutions called Good Stuff, and they really are good stuff. And he's done a lot of stuff in his institution to train peer support people, and even to put it on your name tag that you're a peer support person, and like battle buddies, things borrowed from the military, and post-shift huddles and things, but also giving a roadmap for healthcare workers to get together and address the administration locally about things that one could do on a lower level within an institution to make things better for healthcare workers. So there is a lot you can do. there's also a new book on advocacy by some psychiatrists that talks about advocacy for patients and within the institution and nationally, et cetera. I think, personally, I think that some administrators, at least here in our local little hospital and our rural isolated island setting, the hospital was it was a public hospital, partially supported by the state, which had some inefficiencies, but they ran out of money because of Medicare payment and stuff. So they're taken over by Kaiser. And the Kaiser administration, at least here, has been very unresponsive. A friend who's an ICU nurse, and she's given me all the gory details. So I think they may be changing a little here locally. I guess if you keep reaching out and trying to meet with administrators about problems, just like we persist nationally, we have to persist at an institutional level to change those practices. And I think advocacy is empowering, and it helps us combat burnout. I mean, in 2004, when President Bush got reelected, I felt like I had to fight for something I believed in, and universal health care was one thing. So at least I could focus on that. There's a lot of other social injustices. I think we can't fight them all. There's education, there's climate, there's all those different things, income inequality. But I think if you pick one and focus on that it could help personally as well as maybe in the world.
Thank you.
All right. Well, it doesn't look like we have any more questions.
Well, I want to thank all of you who are here and who belong to SNAP and who are trying to do what you can to make things better. So we think about David and Steffi, who started PNHP more than 30 years ago. They haven't given up. They've published a tremendous amount of research on all these different issues that, immigrants don't use more money and all that stuff. So I think we have to be inspired by their persistence and how long it's taken to win other social injustice issues and ones that we're still fighting about. So don't give up, stick with it. And good for you all.
Thank you, Dr. Gise. Really appreciate you, and especially those last words of inspiration. That's a great note to end on. So thank you again.